are about to start the first live case session today that will be devoted to VT ablation. And the first entry will come from Homolka Hospital, substrate VT ablation with Sphere 9. So we'll try to connect to Homolka.
Hello, can you guys hear us?
Yeah.
Not yet, okay.
Yeah, Dan is speaking. We are together here with Ante Anic, and we can see you. Oh, no, we can't see you.
Okay, fantastic.
Now we can
Yes, yes.
we can see you. Hello.
Okay. Okay, how are you, Dan? Nante. So we're going to go ahead and get started. We're not going to present our case just yet. We just want to present the beginning of the case and then go to some other site, and then we're going to come back and do the rest of the case. So briefly, we have a patient, a previous myocardial infarction, and what we want to do is to get pericardial access with a special tool called the Pericross device. So there's two interesting things that are going to happen at the beginning of the case, which we'll show you. Number one, we want to get pericardial access. And number two, Peter said he's not going to say a word during this. We want to see if that's going to happen.
No, that's it.
It's too late. So let's go ahead and just show a very quick snippet. So Pavel Hala is going to show the technology very quickly, and then we'll start the case.
So good
Pavel?
afternoon. I will start presenting the case of substrate VT with a lattice tip catheter in a post-MI patient. We'll go through the history of this 52-year-old patient later, but we'll start with showing you the technology, how to get the pericardial access. We will use this Pericross device and needle to get the pericardial access, because with this device, we can provide a safe and easy access. Before the needle is inserted into the pericardium, these side hooks, these tines, grab the pericardial tissue and will create a space where the needle is injected, and then the puncture itself should be safe. So that will allow us a safe insertion of the catheter and hopefully a good ablation.
Okay, so let's come back here. Let's come back to thank you. So last year we tried to do this, and we actually couldn't get into the pericardium, as you heard this morning, because of pericardial adhesion. So let's see what happens this year. So all I've done so far is make a nick in the skin, and now this is the obturator, the outside sheath with the obturator. Notice that we're in left lateral position. It just makes it much easier. And so let's see. You can't see the obturator, and the goal here is obviously to get underneath the sternum. So I'm now underneath the sternum, I hope. Yep. Okay, now I'm in the anterior space. And now we're going to put the device in. I took out the obturator. I'm putting in the device. Actually, you know what? Let me just have the obturator one more time. I want to just tent this. Yeah. Yeah, thanks. So let me put the obturator back in. It's always best to go in with the obturator. There, I feel the myocardium. Let's see. Yeah, I feel the myocardium. You can even see some pulsations visually. Now I'll switch over to the device. Then I have a little bit of contrast in a small cc syringe. Inject a little bit here. Okay, that's just to show this. Now what we're going to do is I'm going to preload this guide wire. This is always the tricky part. Okay, the guide wire is preloaded. I'm going to put a little bit of tension. That's okay. It doesn't matter. I put the thing, pull back. It doesn't matter. We don't care.
Okay.
That doesn't look like it's in the right space. Well, it could be. It actually looks pretty good. Okay, let's go LAO, please. Okay, here, Peter. Move over. Yeah. Okay, good. Okay, so let's see where the wire is. That looks like it could be good.
Okay.
Yeah, that's
There you go.
Let me see the left heart. You can see it's
Very nice.
it's not quite there, but yeah, there it
It's
is.
there.
Okay, so we're up against the left heart border. So now we have the small wire in here. And then what we're going to do, I'm going to leave the wire in, and then we're going to exchange over the small sheath here.
But he wants the small.
Actually, I think everybody knows how to get a sheath in, but let me we'll just put this in. Now let me have a syringe, Peter. I want to just show what the fluid looks like. Okay. Actually, you know what? I'll use this one. It's good.
You're a small one. Okay, it's contrast.
Yeah. And if you see, well, I don't know if you can see it. Can they see this? Probably can't see it.
There.
Well, yeah. Okay, here, I'll put it right here. You can try to look at that. Basically, it's fluid. So it's pericardial fluid looks good. So that's just the access. Now just wire the short wire in, and then we're going to double wire the pericardium and then start mapping pericardially. So that's really all that we want to show you. So at this point, I think you can go to a different case, and then when you come back, we'll actually go through the actual clinical aspects of the case and hopefully do something interesting. So any questions on this point, or otherwise we'll go and come back.
Any questions in the audience? It seems that this was very clear presentation. Thank you, Vex, for the moment.
Okay.
You do your job, and
All right,
we'll
very
come back
good.
to you.
Thank you very much, Ante. We'll see you in a bit.
See you later.
The case. Okay. Are you guys here? Did you hear me?
Yeah,
don't have
we
wire.
can hear.
Okay.
Okay, so can you guys hear us again? Can you guys hear us again?
You don't want to look?
Can you guys hear us?
We do. We are back with you. We are
Yeah.
seeing that you have wire in the pericardial space.
Yeah, can you hear us actually?
We hear well.
Okay, great. So what we'll do is, I guess we're not ready elsewhere. So Pavel is going to actually describe clinically the patient, and then we'll move on and do something. So Pavel, please. Pavel, go ahead. You guys, Pavel's not there. Yeah.
Hey, I'm going to prep this.
So now is probably the good time to present you this case. It's again the case of substrate VT
Yes.
with a lattice tip catheter, which we will do pericardial after the access you just saw. The patient is a 52-year-old patient. He has a history of coronary artery disease. He had a STEMI in 2008, which was complicated with ventricular tachycardia, required CPR, and the culprit lesion was in LAD, which was treated with one stent. The patient has a heart failure with low ejection fraction, about 25%. And there is an anteroseptal apical aneurysm, which you can see on these echo images. And the and the ICD, dual chamber ICD, was implanted later to this patient. The other history of this patient includes hypertension, he's obese, he's a smoker, and there is a history of drowning in his childhood which required CPR. He is off antiarrhythmic medication, and about two weeks ago, this patient suffered of this episode of unconsciousness while he was riding a bicycle. He had no injury, but on the ICD history was this strip of fast VT, which had ATP unsuccessful, treated this arrhythmia, but then it was terminated with a shock of 40 joules. In the memory of the ICD were multiple non-sustained VTs of different morphologies. And this is the EKG of this patient currently when we admitted him to the hospital. There is sinus rhythm, scar, and aneurysm on the anterior and apical side of the left ventricle. We showed you the pericardial access, which is already done, and we will show you the mapping of the pericardium and then the ablation.
It was easy.
Okay, so you guys can hear us, right? So let me just show you a couple of things. If you look at the ICE image, you can see the infarct. You can see a large anterior apical region with the ejection fraction, as you saw, was reduced. Right now, we're just pacing the atrium through the device. Let me just show you the fluoro and what we have going on right now. So you can see the patient has a dual chamber device. We have a RV catheter sort of in the outflow tract region right now, and we have the ICE catheter sitting right in the right ventricle, looking across at the left ventricle. We had pericardial access already, and so what we can do is maybe we'll just start mapping around in the pericardium. I was sort of hoping to have done this because I think this is sort of boring for you to watch.
You want to show the endomap?
Maybe not. Should we?
No.
Let's just show this as we're moving. So there's going to be as you can see, there's some very interesting aspects about Affera and the pericardium. One of them is because of its structure, unlike most, sort of regular catheters, there'll be some electrodes that will almost by definition be touching the myocardium most of the time, and there'll be some electrodes that by definition will not be touching and will be low voltage. So one of the problems that we have right now is that the software is not yet, let's say, optimized for pericardial mapping. So we're going to map from the outside. It looks like everything is red and low voltage simply because those electrodes weren't touching anything. So this is one interesting sort of annoying aspect that we'll have to deal with. So, yeah, any questions so far about, oh, one other thing I should say, maybe we'll show. So before we came live, we actually did endocardial mapping. So we got transeptal access, did endocardial mapping, and sort of rendered the left ventricle. So why don't we go, maybe we should just go ahead and show that. Could we show that? Is that possible? Actually, then I have to stop mapping, right? That's annoying. Anyway, so this is the LV endocardium. Let's rotate around. Maybe go to a single plane because then they, or single, one display. Okay, good. And then let's just show. So you can see it's a very large aneurysmal infarcted region. Okay, let's keep going. Go all RAO, please. More RAO-ish. Okay. And then rotate, go apical. Yeah, and then rotate up, show the inferior wall. And so you have an idea of where the low voltage region is, anterior apical. We also induced VTs, and maybe we can show the VTs. You guys on the review screen, the Pruka review. So these are the two VTs that were induced. They were both a little bit slower. Well, they were slower than the clinical VT, which was I think around 220 milliseconds. You can see these are, well, they look like they're opposite. I mean, the cycle length on both of these is about 250 milliseconds, 268 and 251 milliseconds. And you can see they're both sort of intermediate bundle, let's call it. One of them is much more apical with a more inferior exit, but still probably coming from the apex more septally. And then the other one looks like a more basal region that's coming sort of probably at the base anterior wall. So, any questions so far? And let's go back to epi mapping, please.
When you're mapping in the epicardium with the FERA, have you installed any saline to give you more space?
Excellent points. Yeah, so 2 points. Number one, we mapped the endocardium first. So when you took the catheter out, one of the things people have described is the potential for tissue on the catheter. So we watch the catheter, even when we do endocardial, make sure that it looks okay before putting it in the epicardium. Of course, the bigger concern is going the opposite direction. Once we finish epi mapping, make sure there's no fat on it. That'll be a problem going endocardial. With regard to the mapping itself, you're absolutely right. It tends to be, let's call it sticky, for lack of a better word. I like to put I think we put 120 cc's of saline in the pericardium. And the catheter is also irrigated, usually at 4 cc's per minute, and we dropped it to 2 cc's during the mapping. And it does make it, I think, a little bit easier to manipulate the pericardium. Otherwise, it's just very sticky. Let's just show it from the inside. See, when you look at it from the outside, it looks very, yeah, there. You can see that's the real voltage of the tissue, right? Looking from the inside. Okay. Boy, nobody else is ready, huh? I hope you guys are getting something out of this, because this is going to be pretty boring for a little bit.
Yeah, for the moment, yeah, Andrea?
Yeah.
Hey, Vivek and David, it's Andrea here. I just have a question to you, that because I see you only use the voltage mapping. Are you looking at the signals, looking at least manually tagging maybe the sites with interesting signals, or activation mapping, or these kind of things, or not at all?
Well, activation mapping, I mean, I don't know what your feeling is. The activation mapping, we've been pretty disappointed with it, with the FERA system. I think activation is tough with the system, especially endocardio. But yes, particularly on the endocardium, we were tagging potentials that were interesting. The problem is there's a lot of interesting potentials. So it's going to be, we're going to have to, once we understand the substrate, we'll have to use some other strategies to try to identify the best area. I mean, I'd love to do like S3 mapping here or something, but I'm not sure that it's very easy to do that. So it's interesting, actually, we're doing epi mapping, but when you do endocardial mapping, it's very common that you cause ectopy. So you have one of two choices, right? You can go to each location, wait there, wait for a sinus beat or a pace beat or whatever you're doing, and then move on to the next location. That would be, I find, very painstaking and takes too long. Okay. So the other option, which is what we typically do, is just map and we take the voltage despite whether it's an ectopic beat or not. Because we've done some studies, we published it some time ago, that whether or not there's an ectopic beat or a regular beat, you still get a very good voltage map. So that has the advantage of, obviously, of being able to go quicker, but the disadvantage that if you want to do activation mapping or other types of functional mapping, that's harder to do. So, but the strategy I like is define the substrate quickly, get an idea of where things are, and then we can always go back and do careful mapping at discrete regions, not the whole chamber, because that'll take too long. Anyway, I just heard that there's another site that's ready, so maybe you can go there, and then we'll come back, and hopefully we'll have something more interesting to show.
Yeah, definitely, Vivek. We switch for ICAM room.
Okay, fantastic.
See you.
Hello, hopefully you can see us, yes?
We can see you.
So we are in ICAM doing a VT case, and let me first clinically introduce the patient. So it's an ischemic heart disease patient, and will be guided by CT imaging. Can we move to the next slide? And it's a quite young patient, it's a 43 years old. Unfortunately, he's quite sick. He had a kidney transplant about 7 years ago, which is a kind of moderate dysfunction, but there is a function of that kidney, and he has ischemic cardiomyopathy, long history. Even before the kidney transplant, he had a MRI, myocardial infarction, and a year later, he had a CABG surgery at age of less than 40. He had a repeated coronary angiography about 3 or 9 months ago. The Lima is patent, but the rest is not that good. He had an implantation of an ICD. He has an aneurysm on the inferior wall, but there's no thrombus. There was a history of thrombus in the past, and he's on anticoagulation therapy, reduced combined with clopidogrel. That's the strange combination, is because of the history of the thrombus. He's on amiodarone, and despite that, he's a full heart failure medication. Can we move to the next slide? This is the huge inferior Q waves, I would call it, so you have a clue where the probably arrhythmias will be coming from. And if you go to the next slide, this is the VT that brought him. It was just that he had one single episode of this, which is quite slow, and it didn't terminate with the ICD, and it then was terminated in a hospital, and so he was reprogrammed and it was sent for ablation. So generally it's a VT about 150 beats per minute, originating something from inferior wall, lateral, mid, not apical, not basal, like something more mid. And then we started the case. We are using general anesthesia. We have an NSIDE system, and we also have the body surface mapping and CT. So if I can just move to the next slide, maybe if Ivo wants to comment on this, and so I will give word to Ivo.
Okay, thank you, Peter. Hello, everyone. So I will show you how we prepare the cases. So what we usually do is we first look at the imaging. You can see here several projections of the imaging, and this is a wall thickness map. It means that it's very useful for ischemic patients. So in red, it's a very thin area. In less red, it's less thin, and in blue, is thick area. If you can see, there is also this red patchy thing that is also the intramyocardial fat. Why we use that? We combine wall thinning channels with intramyocardial fat because, as the group of UPenn has shown, the presence of intramyocardial fat decreases conduction velocity, changes the impedance, and then makes those channels more arrhythmogenic. So if I had to bet where the BT came from this patient, obviously the scar is huge, so probably many sites can be the BT isthmus, but I think this posterior part where you have the channel and you have the fat in yellow close to the annulus, and in the middle of the wall thickness map, in the mid-posterior wall, it's where I would bet we will find the slow conduction regions. What we have done so far, we have done the transeptal, we have mapped the pulmonary arteries to merge with the CT, so we don't do retroorthotic approach to merge, we just use the pulmonary arteries and either the coronary sinus or either the LB apex points. And Maria is the FT Abbott today. Maria,
Můžeme přepnout na Insight?
Yeah.
Can we switch to Insight for the
and
audience?
show the CT without fat, Maria, please?
Can enlarge the
Enlarge
CT?
CT, don't show the map yet, please. Surprise. Switch off the fat, please, or hide the fat. So here we have like 2 potential channels. Maria, can you put some drawings in the channels, because I don't know why they were not exported. So this could be one channel, okay? And the other one could be the other channel, and probably one in the apical region, the vertical one. Exactly, okay? So these 3 channels, if you incorporate and where I am now, it's also another channel, this vertical one, exactly. So if you incorporate the fat here, you see that this area where I am now and this transversal channel, it's not only wall thinning channel, but also fat. Can you change the color of the fat, Maria, to make it easier to the audience to see, please? Okay, so this is the fat, okay? Switch off the fat again, hide the fat. So this transversal channel, it's long, it's heterogeneous, and it's full of fat. So this for sure will have slow conduction. So second thing, can we switch to the ECGI, please?
Můžeme přepnout v režii.
So this is the ECGI. Can you please run the video? Sinus, please, first sinus. Okay. So you see that this is the region of late potential, so more to the mid-ventricular. So the basal one, it's not clearly seen. You see it from the inside, and you see that in the inside there is in the mid-ventricular. Can you put the mouse in the area of interest there, please? Exactly here. Okay. Perfect. So now the next step, can you move to the inside, please? Next step.
Můžeme přepnout na Insight.
Okay, next step would have been to do the S3 protocol. Unfortunately, despite the patient has a slow BT, only 1 episode, this is a live case. So we induced just by mapping, even without putting a lot of extras, 4 BTs.
Můžeme přepnout Pruka review for the audience. So maybe I will comment now.
Yeah.
Just that this is the VT1, which was then we had a cardiovert. We had to cardiovert repeatedly, like nearly 7 times, because it was very kind of irritative. So VT1, which is more lateral mid, can be more higher on the lateral wall. Can we go VT2? Which is more similar, but more, I would say, more apical and maybe more kind of down on the inferior wall. We can also correlate that with the body surface mapping, but I mean, the ECG for now would be good enough. Can we go for clinical VT number 3, which is much more basal, and it's a kind of low and more septal exit, and VT number 4, which is kind of also more septal. So there are 2 kind of families of the exits, one more kind of mid-lateral wall and one more kind of below his inferior basal, we would say. And we try to really convey the S3 protocol, but it was not really kind of in the sake of patient blood pressure and cardioversions, we had to somehow stop and more move to the kind of sinus rhythm map, because the VTs were very easily inducible. So maybe in the review screen, if you can show some of these potentials, evoked potentials during the S3, so you can see there's a kind of a lot of kind of activity going on after the pacing stimulus, much more than during the sinus rhythm, which you see on the right hand, or during the pacing. So there's definitely some decremental conduction. Can we go for the next kind of what we prepared? Maybe if you want to any kind of comment. So there's a lot of cardioversions because this, and during sinus rhythm, there was good enough. No, we didn't have to actually do the S3 map because there was, as you can see, even some spontaneously decrementing conduction within the scar. So that's definitely a target for the ablation. And
I think sorry to. So I think that this is a key that tells you why you cannot do S3, because we have already decremental conduction in sinus, what is extremely rare. It means that the scar is really arrhythmogenic. You can go, Peter.
Okay, so then we just move and we try to pace map. This is some mid-diastolic activity, but the patient was not very stable. I was not very in favor to map anything during the VT. So we just moved to the kind of pace mapping, the regionalized, the where would be the exit kind of region for these 2. They are not the same, but let's say this is the more lateral mid. And can we go to the other pace map that will be even longer as QRS for the posterior septal, I would say, exit basal. And maybe then we can also show the, because we decided, it was my call, Ivo said it's less elegant not to show all the kind of functional mapping, but because the patient become really unstable, we said we have to be pragmatic, we should kind of go on and start to ablate and modify the region, because the region is kind of a more lateral or going to septal just to make the ablation there. So maybe you, Ivo, can now comment on the VT that we induced. So maybe show the VT.
Maybe before we can see the sinus map. It's a non-complete sinus map.
Can we change to the EnSite?
EnSite, please. Okay.
Not yet now.
So this is the sinus map that we could create, so not a lot, because patient was almost in incessant VT. So there are like two regions. One is here. Show the CT, please, Maria, also. Okay, so you see the catheter where we are now, are in the middle of a channel of the CT. And in this region, we have the latest activity. Can you show some signals there, Maria, please?
So just for the audience, this is activation map, and the violet color shows the latest activation. So this is not a voltage map.
Exactly.
Just for the clarification.
Yeah.
And so it's the late potentials.
Say late potentials
and
here.
You see it.
Show more signals around, please, Maria. Okay. More signals. Look at those signals, are very nice. So then there is a second region, less basal. Show the other region, less basal, Maria. Okay. So these are not as late. At the beginning, we thought it were late. And during S3, can you show the S3 here, please, Maria? Because I think we had beautiful S3 potentials here. Close by. Like this one. Okay, so it seems that all of these long two channels, one basal, one in the mid-wall, are active. And finally, we induced, one of the VTs we induced, but we could place the ablation catheter in the area, because what we think with Peter is, okay, let's calm down the patient, ablate a little without any more mapping, and then...
Can we change to review screen Pruka?
Yeah.
Not yet? Okay. So now you see the VT. This is the one of the posteroseptal exit, basal. And can we show the mid-diastolic activity during the one? We wanted to save this for life, but we have to, that was not really, because we had already really multiple cardioversions and the patient became hypotensive. So this is like something late systolic, nearly diastolic. But can we show the application number 13? Start of the application. So if you have such a signal, can you slow down, slow down, slow down? It took 4 seconds to terminate this particular, but as one of those 4, we're definitely not finished with this application, but generally we want to calm down, but somehow to simplify and make it more, to tend to focus on more stuff. So maybe show on the 3D map. Can we go back to EnSite to show where these applications and where we did stop the arrhythmia?
Okay, Maria, when it's already. Okay, can you show where the BT stopped, Maria, please? So it's this one. And what we have done so far is, here we had also nice diastolic potentials.
If I may stop for the audience, can we go something AP or some just to know what's what? Because we, for the audience, maybe they are not familiar what's what. So can we go for like AP and rotate to the area of interest? Like, yeah, so generally this would be the partially mapped. We have no time to this, so this is LAO, and if you go, it's a basal, can you rotate more? And it's underneath the mitral valve, like inferior basal.
Exactly. So what's the strategy now, what we are doing? We are doing ablation of this region, and in the CT, can you put a more posterior wall view of the CT also, Maria, please? Okay, so what we're going to do is to transect those channels to at least calm down the patient, this channel and the mid-wall patient, and the mid-wall channel that had also slow conduction potentials. And after that, we will remap first in sinus, and if it's in sinus, it doesn't seem to be very, very things, then we'll try again the S3.
So maybe you can show some applications, because go online, Pruka, because we have very nice late potential there, just to see how they change during the application. We have a Tacticat. Tactiflex catheter with kind of contact force sensing, and we will use 35-40 watts for this. So you see the late potential, so maybe you can start to ablate. And
Maria, can you show me the impedance drop? I use a lot of
Can we go to EnSite?
EnSite, please.
So the impedance drop, and show the part when the impedance...
The curve, Maria, of the impedance drop? Okay, show the signal also in the EnSite, because they are not showing the Pruka. the signal now, the live signal, increase the ablation catheter signal in the okay, you see the green is the ablation, so you see the late potentials in the inside. So we'll start ablation and aim for an impedance of 10 to 50 ohms.
Okay, it's gone.
And you see, this is a very nice feature of this catheter that with TactiFlex, the signals during ablation are very clear. Can you switch off to Pruka to show them also the signals, how they disappear in the review screen?
Review Pruka.
In the meantime, I'm ablating. I will deliver like 60 seconds because remember, it's an area of wall thinning of 6.
Show the start of application.
Yeah.
Okay, so yeah, can you show the start of the application? So there you see the late potential. Can you scroll right? So it was a few beats, and it's not here anymore. So it was just a few seconds. Actually, it's 3 beats.
Better
Yeah.
right.
Why we are extending the lesion until 60 seconds? Because the wall thinning here, it's more or less like 5. But if you put the fat here, put the fat, Maria, please. Go to the inside again, please.
Can we see the inside for the audience?
Okay, show the fat thing. You see, you have a lot of fat, so the transmission of radio frequency here will not be very nice. So we'll move the catheter more. We'll try to join also to the mitral annulus because we don't want to like perimitral BT. That's the only line that I used to do when in ischemic patients to impedance, please, Maria. Okay, great.
Any question right now from the podium?
Any question from the audience?
Pretty much silent, you know. So that electrogram, that late potential, really went away within seconds, and it correlates well with what you see on ADAS. It's a 1 to 2 millimeter myocardial thickness there. That is what you expect.
Yeah, but remember the wall thickness you have also to put into the equation the fat and the fact that it's scar. So RF, even in the animal models, in a chronic scar like this one,
So
you
honestly,
cannot.
if you can switch to ice, can you switch to ice just to show you just
Just
another
about to
way?
ask.
So you combine everything.
Yeah.
So can you switch to ice for a big screen for the audience? So maybe you can see that we are ablating something on a thin wall. So here is very thin, very basal, but we are more on a thicker tissue. On the right hand of the fan, you can see the centimeters. So it's more than few millimeters. It's actually around up to like 6, 7, 8 millimeters, the tissue thickness here. If I rotate slightly, just under the valve, you can see that the thickness is really, really small, but we are not there currently. So I believe it's a lot of things that you can combine, and there's a lot of information that you can use for the during the case. Can we switch back to the EnSite map?
That's live case with my cough also.
Yeah, so you have the idea. You have to pull back and stick it underneath the mitral.
Yeah, exactly.
Well, I've seen you ablating with 35 watts. Is that the regular setting? 35 watts, and you said what, 50 seconds?
60, 60 seconds, usually. I think 30 seconds for a ventricle, it's not a lot with RF in a scar. It is in healthy tissue. It was a late potential here that it disappeared again during ablation. If you can
So Ivo, maybe
review
you
it.
can comment also on your experience with the pulse field, the
Yeah.
energy source,
Yeah, true.
TactiFlex.
Yeah, we are doing now ablations based on using a TactiFlex Duo. Yeah, I see it. Coming to the area of interest. Okay, again. So we are doing TactiFlex Duo. TactiFlex Duo allows us to do RF and PF. So RF works like TactiFlex, so normal RF. But PF, it's unipolar PF. And the pulses are like more or less 5 seconds because it's gated ECG PF. So if we pace at 80 beats per minute or just in sinus rhythm, one application, it's like more or less 5 seconds. And what we do in the ventricle is we do stacking lesions. So we do at least 4 stacking PF lesions with TactiFlex Duo. With 4 stacking lesions, you get like more or less 5 millimeters, more or less. With 8 stacking lesions in animal models and in humans, because we have MRI after ablation, you can get at least to 8, 9 millimeters. So what we do is we do RF first, just to see if the signals disappear, and then 4 stacking lesions of PF, and lately we are doing just PF. Why is that? Because we have seen that with TactiFlex Duo, the penumbra area, it's very small. It's so focal that if you do PF and you map just 2 millimeters close, you can paste and you can map signals. So we are happy with PF now. So in this case, for sure, if we have had PF, I would have gone to PF lesions for sure with such a big kind of scar. For instance, in epicardial BT, when we have a lot of fat, we have a patient that had like 3 ablations. We delivered like, no more potentials here, okay, I will move. So we did another ablation in epicardium with a lot of fat, and BT stops in the first application, and it was non-inducible after 8 stacking lesions. So it seems that in fat PF, it's much better than RF. So I will move because I'm stuck here, okay. Let's move to that area.
You're moving to a new region?
Yeah, I'm going to the other part of the channel where I had a lot of potentials. So can you paste here with the tetrapolar to see if we have late potentials during pacing, please? Without excess? Through the ablation
Can we see
catheter.
the match to the VT1? So we have this. Can we somehow make it? So 84.
84%.
Can we use to review screen?
And here, you see here. Ara pasarem.
So we are close to the kind of VT exit,
Yeah.
90%. So generally we should somehow bombard more.
Yeah. Can you show the inside score map here? Can you move to inside, please, again? So this is the other part of the channel. And you see in the inside, you see the shadow of the BT, and in white, you see the score map. So it seems that here, the other part of the channel, it's the exit of the other BT, but probably the isthmus is exactly the same. So it's the same BT using just one channel, one with a lateral exit, this one, and one with a post-septal exit, the BT number 3, 4. So we are going to ablate this region. Show me the wall thickness map again. Can we increase the 40 watts because I have less contact here, please?
No.
Okay, let's see.
I mean, very important. I mean, lesson if the RF should be, these applications should be longer. It's not a fin tissue. If you want to reach deeper with the RF, these applications have to be longer because it's the conductive heating that does the lesion. So you need to generally wait for the
60, 90 seconds sometimes,
for it to be kind of deeper enough. If you do very short lesions, even with a high power output, they're probably very shallow.
Yeah, signals has decreased in amplitude, but they don't have disappeared. So can you zoom in, Maria, please, the CT?
Was there any utility of body surface mapping because the case was declared to be like facilitated by ECG imaging?
Yeah, if we move back to the body surface mapping, please, can you, Esther, can you show the ECGI again? So you see that where we are now, it would be nice to see, I will stop ablating just in case I move. When we are now, can you put the mouse at the exit of this deceleration zone exactly here, exactly? So this region is more or less the septal exit of the channel. Can we see from the inside? Exactly, go. Okay, can you, more in the middle of the ventricle, exactly. You see the exit of this slow conduction region. Can you go for the BT, please? This is the BT, exactly.
BT.
This is BT. You see that it's using this channel, okay, with a small jump there, okay. Can you show the sinus with the same view?
And
Propagate, please.
Propagate. So this is sinus radial with the earliest activation of the septum and latest activation.
So it's more or less the same region. The thing of ECGI, what I look like, it tells you always the most arrhythmogenic area. If you have like 3 areas, probably the slowest ones are very nicely seen to the ECGI. Now we are refining the S3 protocol with the ECGI also to see it, but this is just in a process. But you see that clearly the slow conduction you can have in this patient, you see it here. Okay, can we move to the inside again, please? Okay, let's see if I can get more contact. Okay, can you ablate and pace during ablation, please? That's something you can do with inside. Pace during ablation catheter.
Pace.
Can you pace? Oh,
There's still
it's
some
2 to 1.
capture.
I will start ablating with long stim to QRS.
Can we go online screen for Pruka to see if there is a
And now
loss of capture?
there is no more capture
Okay,
anymore.
can you go review screen and show that there was a loss of capture after application?
It's not like at
beginning
the
of
end
of
point.
the application. So it was 2-to-1 kind of conduction. And then when we start to ablate, we lost the capture. So there's a way how to make some functional analysis of the
Yeah,
lesion, but probably superficial.
yeah. I mean, it's not like the goal, the end point of the ablation, but at least to have something during the ablation.
Can we go back to end site?
Yeah. So we're going to put more lesions in this channel. Then we'll do a quick remap and see if there is something else.
Is it too white? So
Okay,
okay.
okay, okay.
So coming back to the title of the case. So we've seen a huge substrate based on imaging pre-procedural. The ECGI software shows us, one region where you can have an isthmus, region slow conduction. What I have to be honest, the region where you ablated first was not recognized on that because you were doing perimitral. I've seen nice conduction to that region.
Yeah, it's true that close to the valve, ECGI suffers. ECGI suffers in two scenarios. One, it's close to the valves, and the other is sometime in the RBOT sometimes, especially with the old version of the just epicardial, in the septal RBOT. But in the rest of the free wall, let's say free wall, like posterior, lateral, anterior, and septal, but not very basal, it used to work very nicely. So what ECGI tells you is that most of the slow conduction in the scar of this CT, it's in the mid part of the posterior wall. It's true, I agree with you that the more basal one, in this case, it missed. We have
Always
more
nice.
late
You have
potentials
substantial
here, I
lesion below
think.
your catheter.
Yeah, there's a kind of whitening on the locally under the catheter. I don't know whether this is visible for you because of the transmission of the ice might be not optimal, but generally these are microbubbles into the tissue. I believe they just represent that we kind of heat up the tissue. We haven't seen any steam pops, especially with this very scar region. They disappear immediately.
Can we go again
Can
to
we
the
show
review
the
screen?
review screen? Maybe you can decrease the, můžeme snížit ten output na 35 W.
You've seen the review screen, how doing this ablation, the potentials
Zrychli to ještě, no, doprava.
delayed.
So this is the start, yes.
This is the
go.
delay of the late potentials
And that's
they disappear. So we are now closing this channel that it's...
Can we go more? There was some still conduction. Can we go more to the right? So still there,
yeah.
then disappear, and it's gone.
So we're going to close this channel and then probably go to inside the channel to see if there is something else. And then we'll look for the other channel and we will remap because probably there is a lot of still substrate that is still here because we have to ablate more in the middle of the mid wall of the inferior wall.
Guys, I think you consumed already initial 25 minutes of your case. Do you agree that we will go for Homolka just now? And definitely, I'm sure that we will be back at the end of the session.
Perfect.
Okay.
Perfect. Thank you.
Thank you.
Thank you. Can you move to inside, please?
Here.
We are
No,
live.
Fermin.
Okay. Okay, so
Hello, guys.
Good
We
afternoon,
are waiting for your
everybody.
LV Summit case.
yeah, LV Summit Region PVC ablation. Let me introduce Fermin Garcia from Philadelphia, coming for this case. So let's quickly go through this patient, please. One slide. This is number 3 procedure. So this is 60 years old female with hypertension, a little bit obese, but nothing too much interesting. Maybe a little bit mildly dilated LV, but nearly normal. But the problem is here with PVC is about switching from 5 to 30%, now in progression. we see a little polymorphic there, a little bit polymorphic, just not only monomorphic. There's some number 2, number 3 morphology I'll show you later. But here just remind you, we have 4 years ago other hospital attempt from LVOT with 2 morphologies which failed, and we tried Afera on February as well. But it was only temporary effect with minutes, up to 1 hour on department coming back. So now, just soon after 3 months, coming again for this. So please, next slide. Here is one of morphology which is dominant. So we really think about this one is the target. So you can see the axis inferior with little bit white QRS in inferior leads. And there is no transition actually on chest leads, and from 1 is quite high and going through the V6. So we are just basal, really upper part from summit maybe. So we can go next one, but this is not so easy, because you can see one other morphology which is a little bit narrower, and this is a little bit different, not the same. So there is a little narrower, 2, 3, a little higher than previous. And please, next one. And then you can see even other morphologies, not very often, but still this one is a little bit with lead 1, very positive lead 1. So it's coming more from right side base on a little like tricuspid or maybe RVOT or tricuspid or septal. So not very sure with this one. It's not very often, but just illustrating that the situation is a little bit more polymorphic, more complex. So the last slide here, if you can go more, you can see these arrows just to looking during recordings. Just the number 1 has a very small R wave in lead 1. 2 is a little higher and narrower, as well as in 2, 3, and completely different morphology 3 with very high number lead 1. So this is last slide, I think. There was a little bit thinking about strategy. So I will go with Fermin if you want to comment strategy for case.
Well, thank you. Nice presentation. So a couple of comments is, we have a workflow for this situation that it's left ventricular outflow tract. So anything that is left ventricular outflow tract, we follow the same scheme of things. Now, when you look at the 2 PVC morphologies, I don't know what screen you have there. Maybe, can they show the Pruka? Just the EKGs? Or no? Like the review, but go up to only 12 lead EKG.
12 is what tam byte. Nahoru to věď ten.
Yeah, all the way up? Okay. Perfect. The other one too? Yeah. Okay, you can see here the main 2 flavors of the PVC. Now, you could argue they're a little bit different. They're a little bit different just because of, just go up to the 12 lead. No, just 12 lead EKG, please.
12 svody. Nech tam, jak jsi to měl, to bylo dobrý.
Okay, so they're a little different just because of the width, but in general, they look pretty similar. In the EKG, they look more impressive. So for me, the first rule for this type of situation is that right bundle, no transition. It's one of the rules in EKG for me. When you have right bundle, no transition, you have to be very basal on the left ventricle, okay? So you could argue that this is basal left ventricle from the endocardium. This could be LV Sommer. But as soon as you start coming towards the right-left junction, V1 should be more negative. Now, there's, of course, a big variation. There's not a single EKG. So what strategy will we follow? Well, the strategy is based on the history of the patient. These are a patient that has PVCs that look a little bit wider, that might not be typical for an endocardial site, but perhaps the first one is. But these are more than one morphology, but in my opinion, very close to each other. And this is the type of case that would I hope that by ablating in one area, we get rid of both. But you have to find that area, that zip code that I call, okay? So in the history, you have 2 prior endocardial ablations, and particularly 1 endocardial ablation on the LVOT with a powerful catheter that suppressed the PVC and it came back. So either if there is a prior case or not, there is a workflow. And the first workflow that is going to make the decision right away into what is the next step in terms of ablation is to map the epicardial surface of the left ventricle. And that is the epicardial surface of the LV summit. Now, in the beautiful presentation today for anatomy, we saw that you cannot go epicardial for this. So we failed many years ago. So epicardial is out of the question. But what's very helpful for us is the veins, because the cardiac veins are in close relationship potentially to this area, okay? So the first step on the procedure is X-ray number 1. Just go back, go back, go back, go back, back, number 1. And please put the X-ray big, put the X-ray big. That's the first one, okay. So this is how we get access to the coronary sinus. So guided with ice, and this ice is not at that time, by the way. This is the ice right now. Don't pay attention to the ice. We get access to the ice on the CSOs, and then you guide the guide wire. You see that guide wire? That guide wire is all the way in the AIV. This is the best support for an Agilos catheter to enter the venous circulation, and doesn't have the risk of dissection that an ablation catheter would have, or a decapolar would have when you do this. So my favorite way, and what proven in our workflow to be safe, is to put that guide wire all the way to the top, and then you follow the natural curvature of the coronary sinus. So you have to clock a little bit, next one, and then once you get to the great cardiac vein, now go back for a minute. Yeah, stop there, stop there. Once you get to the great cardiac vein, you manipulate, and you take your first picture, because what you want to know is what's happening between the AIV and the great cardiac vein. Here you have a very different type of anatomy. Sometimes it's not there, sometimes. And this is an LAO caudal. So our first picture is an LAO caudal with the catheter at top of the great cardiac vein, and we can visualize here a pretty straightforward curve of the great cardiac vein going to the AIV, or the AIV going to the great cardiac vein. We can also see, because we might be interested in mapping the septal perforator, there is 1 septal perforator, 2 septal perforators, and maybe very tiny LV annular branch. And the second step is 1 image on LAO, so next one, and RAO. Okay? Next one in RAO, you can see, play that please, and you can stop it somewhere in there. We have, again, a good curve, and if you stop there, where you have the branches, just stop there, just stop, and then, yeah. So there you have, you know, those big ones are lateral branches, so you're looking at the tiny ones. Now, this could be good for a guide wire. Something bigger is not going to fit if we're interested in mapping the septum. So now we define the anatomy, and with anatomy defined, my interest is to first map the AIV and the great cardiac vein. Now, under normal circumstances, you can put a smaller catheter, like a 4 French. We didn't have that today for that. We tried to put the decapolar. The problem with the decapolar, the distal portion is stiffer, so we didn't want to push that into the AIV. So go to the next one. So the next step here is, you see that was a decapolar, we abandoned that. Go to the next one. Okay, you see this. So now what you're trying to do, because the curve is kind of straightforward, you can keep support in the AIV. In this case, we're just using the wire, and then the Agilos itself, you slowly advance and you wait and you let the heart itself kind of integrate the Agilos into the venous circulation. You don't push. You play with counterclock up and down until that catheter gets there. Now, for the purpose of this, we said, okay, let's not waste time. We don't have the other catheter. Let's get a good activation map of this vein. So we went now safely, because we have the Agilos there, and put the ablation catheter. So we now perform a map. Actually, you can go live if you want, because we repeated it for you to see, okay? This is live right now. So the sheath came back a little bit. I would advance a touch, because, you know, we've been zeroing. But now we have the catheter back in the AIV, okay? Okay, so here is the map. So you can see here, stop here for a minute. We have the carto reconstruction.
We can see map.
That's the vein right there, okay? Our vector is pointing down. So stop when you have the PVCs, and let's show it. If not, we have recorded. You can show from the beginning, but we're hoping to have some PVCs here live. If not, you can show from the beginning when we said late. Because here, the activation, it's late. You have a low type of EGM. It's hard to capture. And the activation, it was late for both PVCs. So you can put the prior map if you want with the color. She's not having many PVCs right now, but we will wait for them to come back. Now, can you just put eyes for a minute and Carto sound? Make Carto sound big. Actually, don't put eyes, put just Carto, just Carto. Now, I want you guys to remember today on the anatomical lecture, again, was excellent, that when the LV summit was presented, he said that the best way that you can see the LV summit is from the pulmonary artery. Well, I was listening, and I have listened before, and this is intracardiac echo from the left pulmonary artery. Now, don't make it that big so they can see the reconstruction, okay? So when you advance the intracardiac echo into the left pulmonary artery, you see that structure right there, the circle. I don't know if somebody can point it, but the main circle on the center, that's the LAD, okay? That's the LAD, the pulmonary artery is on top, the left ventricle is on the bottom. So you can see on Carto, as I clog my catheter, I'm going to open the appendage. You see that? That's the left atrial appendage. Now, you remember today he mentioned that you could map from the left atrial appendage. I would never ablate from the left atrial appendage, but I could map. The circle that is next to the pulmonary artery is the LAD. So you can see also in this patient, there's not a lot of fat. And he said very clearly, the fat is our enemy here, and I agree with that. So if you look at the fan from the Carto, as I clog and I manipulate right, left, I'm gonna open more the LAD, okay? And I'm gonna go slowly until I find my tip. My tip is going to be somewhere in here. Now, pay attention there, and as you know, you're gonna see a green tip. So you can pause it when you see the green tip so we can show exactly the relationship, okay? So we're going like this, and we're gonna show there, the green tip. You see that? I'm gonna leave it there. That's the green tip. That means the location of your catheter. So that catheter is far away from the LAD because it's surrounded by fat, and it's right at the top of the epicardial portion of the left ventricle. In the bottom, you see the cavity of the left ventricle, and it's below the left atrial appendage. And that's the relationship we saw today in the anatomy lecture, okay? So we know here that this is true LV summit. And in true LV summit, our activation is not that great. So what we did, why don't you show your activation map? And I don't know if anybody has any questions about this view, or you want to add something, my friend, or we can say more. But we did an activation map. And then what we did is we slowly pull back. Now make the Carto bigger. Make the Carto bigger. Take out the left made in the circumflex we reconstruct. We'll show that later. Just take it out for now, okay? And we just simply, you can see on fluoro, we pull back. Unfortunately, I think we suppress the PVCs because we've been waiting a little bit. But I'm pulling back. Now, as I pull back, I'm going to follow my ICE catheter. That's a PVC. Show that now. Show it live. Show it live, the PVC on Pruka. Can you show it on Pruka? The PVC just now? Can he show it on Pruka? Is that the PVC? No, go back, go back. There, you see that? You start getting earlier for the PVC that looks wider. But you can also notice that the proximal signal is earlier than the distal signal. And this is the key. You're going to come back until you bracket the PVC in the earliest place, the late place forward, and the late place backward. And that's where it's going to give you the best spot. Now here, we simply start coming back on this location when we were having a lot of PVCs. And that's where you see that we were early. And hopefully they come back. There's one, so you can see there the location, right? So with intracardiac echo, I'm going to follow myself to where that tip is, okay? And I'm going to show it to you. Make the echo bigger, please, and turn it around for me. So as you come back, okay, as you come back, it becomes more difficult to see it because now you have a lot of fat. So because our friend, the left atrial appendage, was there, we did a transeptal. This is how you advance eyes in the left atrium, by the way. You find your wire. We have it right there. Just 1 second. Yeah.
Can you please remind
Okay,
us
that's
that
eyes.
you
That's
know
eyes. We just
the
advanced
last
eyes
ablation
onto the
patient
left side.
received, he also received
Okay.
ablation in great cardiac vein. Was that with RF or PFA?
We haven't done anything yet.
No, not today. The last procedure patient received.
No, nothing in the great cardiac vein.
Then it was just Affera, and we tried to
From the endo.
from LVOT, navigated by the distance from CS catheter as well. Then we tried as well to go with sphere catheter to very distal coronary sinus and put PFA from there, but it was just the temporary. And the effect looked nice from some minutes, maybe a little longer, but then it's coming back everything. So now the strategy is more precise from mapping view, let's say. So we are.
But you can see that depending on how your catheter is directed in this area, you record a big A or a V. Now, this, what we just did, is we advanced the eyes into the left atrial appendage. Now, you can see this clearly there, right? And when you are in the left atrial appendage, you can do a couple of things. You can find the left main by simply pulling back and looking for the aorta, okay? So this is the left main. Can you guys see it? That's the left coronary cause. That's the left main. Behind is the right atrium. And the other side is the pulmonary artery. So now I advance carefully into the left atrial appendage, and I look down. Right there, you see my fan. You see my fan? Fantastic. Okay? Okay? That's the vein, and that's the artery on the left. Now, in the vein, you can say, Fermi, well, how do you know that? Well, I know because they move different. The artery doesn't move that much because it's surrounded by fat. The veins look different. But the reason you're going to believe me is because I'm going to show you the green marker. And when I show you the green marker, you're going to see that the green marker, it's right there. So move my map around a little bit, please. Okay? No, move it around so I can see where it is. Yeah, I'm too interior. So I'm going to come slowly. And once you caught the green marker, you see that? That's the green marker. And that's the circumflex. I can tell you we are almost a centimeter by the circumflex, surrounded by fat, and in the epicardial aspect of the LV summit going to the base of the heart. Now, with me lately, this has been enough to do the ablation, but of course, we don't want to risk anything. And a coronary angiogram was performed in this location, so you guys can show that, please.
You want to show?
Live ECG
Yeah.
as well. Let's say.
Don't far up, please.
Yeah. Yeah. That's a PVC there. Show the activation. Yeah, show it to them.
Update. The timing is now the distal is
Yeah,
coming back.
that's good. So we're going to show you. So this eyes view for me is priceless because you can see the location in the left atrial appendage and that fat pad. The fat pad is very small.
Can we show?
Yeah, so this is the coronary. This is an LA caudal. Okay?
Show that.
Just play it. This is the same catheter location that the eyes picture is showing you. Okay? And then,
Štěpáne,
No, that's
dám
it.
tam fluoro teďka.
oh, guys, can you show the cine, please? There. That's the artery. You see that? That's the same location. You can see exactly that what eyes is showing you is exactly what eyes is showing, what the angiogram is showing you. We're not close, and then we did an areocranial. So show the areocranial, please.
Další. Aha.
There, you can see that we're in front of the circumflex and above of the marginal branches. Okay? So the workflow is simple. You start on the epi. I started on the epi, particularly because 2 good endocardial ablations have been performed because of the EKG. And once you find this, there is no reason to map the epi. If we can deliver any type of
Update
energy
Pruka,
here,
Ukaž, update
it
Pruka,
should
okay.
work. Now, please, before we do that, show the 99% pace map, please. and show when we have the two morphologies. Show when we have the two morphologies.
Ukažte both tam.
Both. Now, make that bigger, move it to one side and the other one.
Trošku to posunie tu šablonu.
Make the review smaller. Make the review smaller.
Trošku tu šablonu si menšíme. Tak, a to je
Yes.
moc, to je moc.
Now move it this way. No, the other way, my
Šablonu
friend.
trošku ukáž, ať tam je vidět ta šablona.
Yeah, I want you guys to see this. You see that? The two morphologies, the narrow and the wide. On the wide, it's earlier on the proximal. In the narrow, it's early on the distal. So you have two morphologies that are very close to each other, and we have good pace map for each one of them. Okay? Show the pace map if you wish.
Máme ten pace
Also,
map, ještě ukážeme.
or we can repeat it.
A šablonu
There.
trošku vytáhni tu
Okay,
šablonu.
and then put it next to each other. This gave us a
Trošku stáhni
97%.
ten lob.
Okay, just put 12 lead EKG to 12 lead EKG. There, 12 lead, 12 lead, and you can see that it's pretty good. Okay? So we got to this spot, we're safe. The last thing you need to do is you see that vector on Carto, put Carto again, please. I need to play with this vector to point down, like that. I don't want the vector pointing up. I want that vector pointing down. The contact force doesn't help, but the vector helps. And that's going to give us the best possibility of being here. Now, I want the green marker again to confirm that I'm pointing down, and you can see that. I'm going to bring the green marker there, right there. You see that? I'm right on top of here. I wish we had PVC so we can ablate and show.
We can show
Maybe
live.
wait a little bit. Can you put the screen at 50?
What's your
And set
starting
up for
impedance in
20
that
watts.
position?
Yeah, what is the impedance?
We cannot see impedance. Can you
Yeah, we'll
log
show
that,
you. We'll show you.
semaphore?
Pane, dej tam live EKG taky ještě.
160.
Dej tam
Carto,
oboje, dej tam
Carto,
oboje,
160,
ty karto.
okay,
jo.
160.
Yeah, just make it higher for now and see if it works. If not, we'll have to modify the patch, maybe put it on the
Okay,
chest or
this
something.
is good. So we have everything in the screen now.
But we're going to start low and see if we can get a lesion here. Sometimes I like to perfuse at the maximum, so can you perfuse at the maximum with Thermocool, please? Yeah, whatever is the maximum, 17 or 20.
Mechanical.
Yeah, the pressure might be suppressing it because we haven't seen it, but maybe if I release a little bit.
Sometimes it's
I'm gonna
heart rate
release
is
a
a little
little
bit
bit.
higher heart rate, so it's
No, it's like faster, but no, it could be even pressure, right?
Yeah, it
Think
could
you're
be
having mechanical
pressure.
bump?
Yeah, because look, I
budeme
leave the
dělat
tip,
stud ablaci,
I leave the
bude
tip,
cítit takovou bolest.
I leave the tip, and they come back.
Teď
I
na
put the
chvilku,
tip
jo,
down
jak se
with good
nalekejte,
pressure,
no.
and they go. So, okay, are you guys?
Teď
Oh, yeah,
budete
now she's
furt
talking.
tlačit, jo.
Not the right time. The second. That's good. More PVC. Now, is she awake? You are ready for 20? Wait, I just need to get my vector down again. Just give me 1 second, please. Okay.
Okay.
You see, point down,
Just
PVCs go
mechanical,
away.
Yeah.
How do we do this, Peter?
Just mechanical.
I don't know.
Because of you.
Maybe we
You know
ablate a
what?
little bit forward.
For this space map, even Mark Josephson will be happy.
Okay, maybe we get some PVCs here. Maybe talk to her. Maybe she wakes up a little bit. I don't know.
Jo, trošičku.
She
jo,
tip up,
tak
tip
v
up,
pohodě.
PVCs come
Jo,
back.
tak se nebojíme, aby to tak chviličku tam trošku tlačit jenom.
Tip down, PVCs go away. I guess that we wanted to show the suppression with RF because that would be good to know if we deliver a lesion or not. Yeah, okay. So I'm going to put the tip down again. There, okay. Come on at 20. Oh, they're gone. Now stop. They went. Okay, go ahead, 20. This is so close, and you can see eyes. Make eyes big, please. Make Carto eyes big. I want you to see the tip. Okay, I want you to see the tip because you're. Show me the fan. Show me the fan. Okay, that's fine. You can see it's getting white.
Yes. Look. Yeah.
Now, a Fera would work here from the endo if you were opposite to this spot, but it's hard to be opposite because it's a smaller space. You can do 60, we can stop and see if it works, and then we can repeat again, release the curve. Okay?
So for me, I don't have to reduce 22 degrees, showing something is it real here, typical.
Yeah, I mean, we could.
Start cooling.
Okay, go to 25. Go to 25.
No, sorry.
Start at 25.
It's like strange temperature.
I know, but there's all the parameters. You're just hoping to get a 20. Go ahead, do 25. Yeah. I'm gonna do one a little forward because that was the other location, and we're still safe with the artery.
Maybe the cooling effect is like
You guys can see on eyes. So you have eyes. You can see the white dot of the catheter on the vein. You see it, right?
It's right there, right?
So here is the other one.
Yes.
it's the narrow one.
So we're gonna go forward a little bit. That's the other one. This is the one that is a little bit backwards, so we'll come backwards a little bit.
Do you anticipate you will have ablate retrogradely to reinforce the effect?
Well, that's a good question. I think if you ablate here, you wait, and they go away the way they went now. There's no need, but you're right. This is a third time. To have an arterial line, it would be very easy to put the catheter opposite from the endocardium. So it's a good idea. I would consider it. I think it's a good idea just to make it better, especially because we're ablating from the vein, and you don't know. But in my experience, if you get this type of suppression and this type of elimination with a perfect mapping and a perfect pace map and not a lot of fat, this is very important. Look at that. There's not a lot of fat on this annular region, so this allows RF to get there. I think that this is pretty good, but if we maybe we'll do a little bit opposite as you suggested, Chris.
We'll go from this side.
Are there any questions from the audience? If not, Fermin, we would like to switch back to ECAM, and if you wish, we will come later just to conclude
Yeah,
our
we
case.
can come back and tell you what we are doing, okay?
All right.
You
thank
can turn off, okay?
So
That's
this
a
is
big
better.
glitch.
Okay, so we
First,
just
we will visit
there
Ivo
and
Roca
there.
and Peter Beichel.
Can you
EP
compare with the
room,
other map, please?
And then we will finish with
Okay.
Christian Chilo. We can see you.
Okay, so we are live. Welcome back. We spent a lot of time on ablating on the lateral mitral or basal mitral isthmus, and we got rid probably of these two morphologies, which we're having exits towards the posterior septum, but we are now remapping more kind of apical region or mid region of the lateral wall. So maybe if you can show the EnSite map. So we have HD grid. Can you switch to EnSite? So what is happening is that we kind of using HD grid to do the sinus rhythm map. We don't do the S3 protocol. Just kind of cleaning and see what's left. And there are still some sites which have a very nice late potential. Can we show in the review screen some of these late potentials that we had?
And I will try to go with the grid also live.
Or maybe live with the grid. So.
Now we have some late potentials.
So maybe for the real life, can we switch to the live screen? So you still you don't see the Pruka live. So hopefully this is more ablated, but then you see these potentials probably have to go. So the scar is quite large. And we had seen one more time the VT with more apical exit, and we had a perfect pace map for that. Closer to the region, to the apex. So this is the sinus rhythm map, what you see in the EnSite, or this is the VT.
No, the sinus rhythm map in the left, and in the right it's the pre-ablation sinus rhythm map. Is that right? Can you zoom in, please?
Okay.
So you see that it has changed a lot, especially this region where I am now, that it's pretty clean, but there's still some residual late potentials in the more basal side, where I'm going to show you, like here. Okay, can you show the latest potential in the EnSite, please? So, okay, can you zoom in, please? And the signals. So this region Where is, okay, and can you show where is this in the CT, please? It's where I am now, so probably we'll need more ablation. Show the CT, please, Maria. So it's a typical example where despite having a nice map, a nice CT, the main problem is the lesion size you can get with a ref. Can you put a okay, it's just in the middle of the channel where we have not ablated yet. Is that right, Maria?
And there's another factor, is if you look at eyes, so keep it there. So if you just keep it there.
Yeah, okay,
so maybe it's visible on eyes that you're just in the middle of the papillary muscle. You're inserting it within two heads. I don't know whether you can see on eyes, but generally we are somewhere in the papillary muscle. So it's another structure that somehow prevents you, and a beautiful electrogram. So the base of papillary muscle obviously is an obstacle to manipulate, and also for HD grid, but I believe we are now nicely stuck inside the papillary muscle in between these two heads. I mean, that's clear, and the signals are beautiful. So more to be ablated. We also may show the pace map for VT2. Can we go for the review screen to show the pace map for VT2, which was this one. So this is the still one that is inducible, and we will have to ablate more, obviously, for this one. You don't see that. You have the inside.
Yeah. So all of these regions are the regions that we have to re-ablate. The rest is clean. You see the ablation dot that we have done in the most basal area, it's clean, but this close to the papillary, so anatomy again, close to the papillary are still residual lesions. So we will re-ablate that region. We will re-ablate the apical exit of the more apical channel, and then we will remap and we will reinduce. That's the strategy that we are going to follow. Unfortunately, we cannot do functional. This is exactly where the mainly the ECGI told us. So this posterior, the real posterior wall. So this is again, let's go again to the region. So this area we ablated, and you see that the area we ablated, we have almost nothing now.
Can we see the electrogram from the Pruka Live? So there is some late potential, but they are blurry, they are far fieldish, they are like a slow. So they are not as nice, juicy electrograms that we had in the very beginning. But when we move to the kind of more apical region, we will again start to see those interesting electrograms. So it's more like the scar is quite huge, so it takes some time. This is, I believe, beautiful. So it's more to ablate, more to do.
Better. I think
This is
you have a
clean
complex
also
case.
just
It's
in the
extensive scar,
ace
and I
blind
think
close
it's
to the
we're gonna
papillary.
say last 10 minutes for you. We're gonna let you work because based on what your predefined lesion set, you have the work to do. Really, you have a lot of work still to do. So maybe we leave you at rest. You do your best, and then we come back to you, and we're gonna say last 10 minutes definitely for your case because it's most complex. It's a young guy, and do your job.
Okay, thank you.
See you again. So
Okay.
now we move to EChem. We move to
We're gonna
EChem,
do ablation.
to another lab,
Let's-
and we're
let's
going to
map these
see
regions just-
ablation of ischemic QT guided by pace mapping. Christian De Chilo and Professor Kautzner.
Dejte mi to odpustit, tohleto blbinec.
All right.
Hello, EChem.
Hi. We have problem that we could not induce tachycardia for a long time. Then we induced tachycardia, which I don't know if it's the one which comes from the real aneurysm, but maybe we will introduce the patient. Peppa.
All right, can we get the slides, please? All right. Okay, so this is a 61-year-old male, a diabetic on per antidiabetics, an obese patient, hyperlipidemic, who has ischemic cardiomyopathy. He had an inferior ST elevation myocardial infarction already almost 10 years ago. At that point, he had an ejection fraction 35%. They stented the right coronary artery, which was the culprit, but he already had chronic total occlusion of LAD at that point. And then there was a significant non-culprit lesion on the circumflex that was stented in second step in 2017. He got an ICD in primary prevention, and then he had a coronary angiogram evaluation last year, or this year, I'm sorry, where the circumflex is patterned, but he had the well-known CTO LAD and a new chronic total occlusion of the right coronary artery. Currently, his ejection fraction is 30-35, and on transthoracic, he has large substrate, apical septal, and on the inferior wall. Can we see the next slide, please? Here you can see the large substrate on transthoracic echocardiography, which is mainly in the septum in the anterior wall, and you see the second substrate on the inferior wall. Next image, please. Here is the CCG in sinus rhythm. Next image. And now what happened was on 9th May 2026, he had an electric storm. He had 8 shocks for fast VT, 260 to 270 per minute. He had repeated restarts of the arrhythmia after therapy. No clear trigger. He was hospitalized in local hospital, started on amiodarone, which was now withdrawn, and he had no recurrence since. And that is the current status when he was admitted for this ablation. Here you can see as an example of one of the ICD interrogation delivering the therapy and the restart of the arrhythmia. And that is all. Thank you.
So basically, we did transeptal puncture. We started to map left ventricle. We have some nice images of left ventricular scar. If you can show it, somebody, we were recorded for you. So now we are in the right ventricle with the ICE probe, but we were most of the time in left ventricle. And there is a huge aneurysm anteroseptally going to inferior wall. You see now the image on ICE. This is from left ventricle. You see the septum, and you see the big aneurysm, and which is which is bulging into the right ventricle. You see the defibrillation lead somewhere there, and you see thinning of the wall. To our surprise, when we could not induce tachycardia, we paced from right ventricle, left ventricle, then we gave some isoproterenol, and we induced rapid VT, 240, which might be more or less a similar cycle length as arrhythmia, but you see morphology which does not fit to this apical or apical septal aneurysm at all. So this is from basically upper part of the basal septum. And we did this space mapping in this area, and maybe Christian will explain you now more. You have to tell them what to put there. So we give there a map of the carto. Tak ať si ho vezme. I can't comment this because. So you should see carto map. Can you put carto map into the main screen? Okay. So here is the RAO view.
This is not RAO.
Or kind of modified RAO. With downward tilt, if you want to be precise. Can we see also VT instead of ICE? We give there VT during this VT, the screen. Okay. Can you see the ECG?
Do?
Can you switch out the ICE image and put there this static screen of Pruka? Okay, now we see it. Okay. So you can explain it. To jsme mohli udělat snad před hodinou. Okay, so we did pace mapping for this rapid arrhythmia, which is from basal septum, and these yellow points are points of pace mapping. And in color, we should be improving accuracy of matching with the template of arrhythmia. And we reached, I think, 84, which is in this red area. So this is close to exit.
Yeah.
But we could not find. And,
if I can
okay, now Christian has already a microphone, so he
sorry,
can continue.
But if we look at the 12 VDCG of the VT.
Can you hear him?
Barely.
Yeah. If you look at the 12 EDCs during VT, so we have the onset of the QRS complex and the offset in between these two lines, blue lines, and there is some slurring, especially when you look at V4, V5, V6, but also in lead 2 and in lead AVF. But clearly this is coming from up, and with the transition, which is here in V2 or between V2 and V3, we expect that this is coming from the left ventricle. So that's the reason why we paste here at many sites in the left ventricle. And you see here with the color coding range above here, the correlation here on the left is 40%. So everything which is purple is less than 40% of correlation. And the best site was 84. So we have a very tiny area here just below the aorta. It's just at the junction between the aorta and the left ventricle where the correlation is 84. So that's the type 2 that I showed you before. So this is not the exit, I would say, in terms of endocardial circuit. So it suggests either an epicardial or maybe something coming from the right ventricle. So that's the reason why we moved to the right ventricle and we paste the right ventricle. So you will see it right now. And when we move all around, you see in the right ventricle, this is the septal view. You have the septal view of the right ventricle. The orange dots correspond to the His here. And what is above, just in front of the area where the pacing site was 84, so in the right ventricle, the best here is 30%, maximum 29 to be precise. So clearly this is not a good area. So this suggests that it is coming from the epicardium in the Elvis summit.
Any
so we went
right
in the CS with the ablation catheter.
No.
So you have the we have the ablation catheter here in the CS, and again the percentage of correlation is low. See here in purple, but could not possible to advance the catheter more than that. So Joseph changed for a smallest catheter. You cannot see it on the screen, but pushing the catheter deeper in the CS, it could arrive approximately to where you have this arrow moving right now. And here, again, the percentage of correlation in this area was around 60 to 70 only. So different options, either it's intramural or maybe this is closer to the cusp, but
we can go to the right cusp. We can change the sheath and go to the right cusp, and then. But anyway, besides this arrhythmia, I think we definitely will go to this apical aneurysm because there are late potentials. There is slow conduction. There are channels of slow conduction in that big apical aneurysm. We show you in that image of intracardiac echo. So you see it also here on the map that there is a huge aneurysm, anteroseptal and the inferior wall. So I think that would be for modification of substrate to, let's say, either a core isolate or do some, let's say, destruction of all late potential areas and these slow channels. But now if we are talking about this pace mapping for that particular arrhythmia, we will exchange the sheath and go to right cusp, because there might be another area, right cusp, or just endocardial close to the aorta, which might be maybe the site of like entry to this circuit.
If you look at the pacing sites, which are very good here in red, 84, you see that there is a gradient. If you go below that, you see that you go from red to blue, so it means that the percentage of correlation goes between 84 and 40 in a very small distance. So there is some conduction delay here between this zone and the rest of the septum. And it fits with this wall thickness, which is thin, and echinacea in this whole anterior wall here.
I'm just gonna remind the audience that what we are seeing right now fits well with one of the scenarios Professor De Cilu, stated in his lecture. So the intramural.
Yes, the second scenario.
Yeah, if it's intramural septal,
Yes, that's it.
It doesn't look like a simultaneous exit. It's not that narrow, but also it doesn't look very epicardial. I don't know where's the origin, but the exit is not so epicardial because I haven't seen too much of the epicardial features in EKG.
We will do some ablation there, obviously, but we did not describe the whole circuit, which is obviously not so instructive as we expected. But we tried our best. We went even with, it was very difficult to get into coronary sinus. Finally, we cannulated. We could not get there with ablation catheter, so we used a sheath to support this micro catheter for French, and we were in close to this takeoff of anterior vein. But then I tried to push more, and it kicked out everything from the coronary sinus. So we lost this, and there was no good pace map anyway. So it was not helping. So we can now go to. Já jsem vlevo ještě, že jo? Tak to tam necháme, ne? Propáchni to ještě. Okay, so we can go now. We can go to right cusp.
I guess there was also no SQRS delay in this red region during pace map, because it's.
There was some small, but not particularly.
Yeah.
Much bigger delay was in apical aneurysm, obviously, but there is a big scar.
Let's go back to the cycle length. Cycle length is extremely short, so we really don't expect too much of the
cycle length is similar to
incremental tissue.
The induced VT, the heart rate was 260, and which matches the spontaneous VTs in these patients.
Okay, oops.
And was there any signals of conduction system proximal here at this region or not?
Yes. Yes,
You see,
there
these
was
are the blue dots
anterior
that you see
fascicle.
here. The blue dots correspond to the HIS.
Okay, can we map? I can take a point, not FAM, just take me point by point, okay?
A nice cross section of aorta on ice.
We call this
Give
Mercedes
me
view.
AP.
Yeah, you're close here. Yeah.
Yeah, this is Mercedes.
Yeah.
So we are now in right cusp.
Yeah.
We can pace from here. There's some fragmentation, as you can see.
Yeah.
But
potential.
Yeah, there is capture.
Yeah.
What's the match?
Yeah, it's better.
It's 88.
88. We are close, yeah. Mm.
So I will move towards the left commissure.
Yeah.
Can we rotate to the left? Yeah. So we are now a bit closer, but not yet on the commissure. Can we pace map here? Okay, it's too lateral already, I think.
Yeah.
I think the audience, if you show us the ice, you can really appreciate how close are you to epicardial RVOT, posteroceptal epicardial RVOT.
Yes.
Well, we can add the right ventricle on the opposite side if you wish. So you will see.
Beautiful.
Yeah, you can give a right ventricle.
Yeah.
I can go now backwards. Yeah.
So you see the right ventricle. Maybe
Okay.
we will have some transparency.
I can go towards
on the right
non-coronary
ventricle.
cusp because that would make a bigger amplitude in lead one. This is fragmented, pretty
Yeah.
fragmented.
Yeah.
Let's pace here. Yeah. Okay, I think that's probably the thing which we can get here.
Yeah. Maybe what we could try is to decrease a little bit the output.
Yeah.
To see whether we can entrain at the site where it was 88.
I like the fragmentation. There is conduction delay, but
Yeah.
is not any better.
90%.
90%. So
But could you
Yeah,
give
you
us
get
12
it,
lead? Could you give us 12 lead?
you have to decrease a little bit
12
the
lead,
output here just to be sure that you are really capturing
Of what?
locally.
12 lead
Yeah.
of pace map or
pace
No,
map
I
and,
mean
and the VT
if you increase the output, the size
Okay.
of the virtual electrode gets
Can you
larger.
give them 12 lead of this screen, this static screen? Can you show it?
Yeah.
Okay. On Paso it was 90.
Yeah, it was 90.
This is not
but-
perfect, fit perfectly aligned because this is from Pruka.
Yeah. Yeah, with
But
the
it's close
with
to
the
90, I
yeah with
see.
the Carto it's 90. Yeah. Maybe we can try to pace again here and decrease. Oh, the output is 5. It's okay.
Well,
You have to increase a little bit. Yeah, and we'll see. When okay, we capture
I'm
here.
pushing the.
Yeah, we see that.
I'm pushing
Yeah.
down.
It's 97. But you get the 90, and I think, well, usually in those areas, it's very difficult to be above 90. Huh? 95 is very unusual. So when you see that, it seems that we have some epicardial connection from this side going to the
Yeah.
My
the
question
90,
is, when you're
the
pacing from this
84
spot, what part of the heart are we
percent of
capturing?
correlation zone.
We are capturing, I think, surrounding myocardium
Yeah.
in between right and left,
Yeah.
because there is still some extension of septum
Yeah.
between the both vessels. So we are capturing this area. The alternative would be that we are capturing some extension, but that's in that case. I would expect some.
Yeah, it's very nice signal here. You see the
Greater
signal
arterial
you have,
potential.
very nice.
Okay, we don't have that.
But I think in this area, often there is part of circuit is this area.
Yeah.
So I would ablate here.
Yeah,
I would
I
ablate
agree.
here.
Yeah,
I would
yeah.
ablate contralaterally in left ventricle, and then we will focus on substrate modification in this apical area, because I think we have to modify that if we are already here. But for this particular arrhythmia, probably it's this clinical arrhythmia, which
Yeah,
is very
yeah.
fast.
Yeah.
And I do not expect very fast arrhythmia from this apical aneurysm.
Yeah,
So
yeah.
I think it's quite complex case. But I believe that we showed most of this pace mapping, let's say, principle.
Yeah.
And we mapped all chambers, even this anterior vein, at least the proximal part of anterior vein. And
And if I may, Joseph, you see, the percentage of correlation you have here is 90%. And in the opposite side, if I could call it like this, I mean in the ventricle, which is very close by, because the blue dots that you have below here, you have, the distance is something like 15 millimeter, not more. Even maybe we're going to measure that between here and here. The distance is, it's 15. Huh? So 15 millimeters from this side, you go from 90 to 40% of correlation. So we have a big gradient. And this correlates with the fractionation that oh no, it's -5. So the site where she's showing to you right now, between this point and the other one, 90%, you go from 90 to -5%. So you have a 95% difference in terms of correlation over 15 millimeters. So we have a slow conduction from the site of origin to reach the part of the septum, which is very basal. And it's faster to go to the interior part of the left ventricle, because we go from 90 to 84%, so it's pretty fast to go this side here. So it may be possible that we have some re-entry mechanism going from this site of origin and going a loop like this. That would be my interpretation here.
so where would you ablate?
In the red.
Yes, I assume as well. I don't have such sophisticated map, but I make it always in my head. So.
Wait, we still have 45 minutes
Okay,
into this session. I think you have to do ablation here. You have to
Yeah,
do
the
the
signal you have
substrate,
here
the
is very
apical.
nice, huh?
Maybe we can come back to you
Very
later on just to see
fractionated.
if you made this clinical arrhythmia non-inducible by ablation in this part later on.
Yeah, but remember that we induce it only after after
After 30
administration of
minutes,
isoproterenol,
after
we were
30
trying
minutes
30
trying to
minutes
induce.
the arrhythmia. So its reproducibility of induction
Yeah,
is probably
yeah, yeah.
not very good.
Yeah.
Fair.
But anyway, yeah, you come back. We will work in the meantime.
Great. Do your job and hear from you later.
Okay,
Yeah.
thanks.
All right. I think there was
Pošimrejte mě na nose.
Vivek doesn't want to be in live just now. Vivek, yeah, so you can switch.
Vivek, can you hear us? Devi?
So Fabian, I think you go live now for slowly.
Yeah. Yeah, now we did from both sides.
Yeah, live now.
We see Fermin. Maybe is it all right?
Yeah,
I don't
hi.
know
Yeah,
what
we're
is
good.
preference, Vivek or
So
So
we did the ablation as we show you, and as Dr. Shilo recommended, something in the endo needed to be done. But actually, the PVCs came back mostly with a narrow configuration, not the wide configuration. So we went just with Thermacool again to the opposite side. I think I saved an image. Can you please go back and the image? I know. But on the image saved, can you put the fluoroscopy image? I saved one. You can see here, I put it in Carto for you. Just go forward. No? Just forward? No?
This is last one.
Okay, so I didn't save it, but here, I can save it now because I'm there now. You see, it's like right opposite to that area. This is why bipolar also worked before on this. But you can see on Carto. Now go back to Carto and make the Carto sound bigger, please. The eyes on the Carto sound bigger so they can see the green dot. And you can see there that we apply few lesions from the endocardium right opposite to the vein. You can see here we're right opposite to the circumflex. So I guess the consideration here, if you were to use PFA, you're pretty close to the circumflex. I don't know any experience of that. Obviously, RF would work. But we put a few lesions right opposite to this for the more narrow PVC that we were early, like 30 milliseconds. And so far, we haven't had any other PVC recurrence for at least the last 10 minutes. So we essentially sandwich the epicardial aspect of this region in ice with the endocardial aspect of the opposite to it in the very basal left ventricle. And so far, we haven't had any PVCs.
And Fermin, what was the opposite side? Was it like below the left cusp or more or less close to
You see, now we're
aortomitral
having another
continuity?
variation.
Or how would you like to describe this endocardial side?
No, this is a catheter. The opposite look pretty normal. You can show them there when we ablated. Actually, look at this. This is now a little bit different morphology. It's more positive in that one. It's a higher up, so even more medial or more lateral. But you can see that in a way we're changing the exits of this region. Even though it look early for one on the back, this one looks a little bit different. And it's just happened a few of them, but we're going to keep an eye on it. Could you please repeat your question? How good we look in the endo? Can you please go back and show the electrogram?
I was interested. How could you describe the endocardial success site or this contralateral site? What was it like just below the middle of left cusp or closer to the aortomitral continuity or any?
Okay.
Because it is not clear from your map, at least for me.
You have eyes right there. So this, I'm going to go back. Okay, show you here. Okay, if I go back here. Okay, I go back here, okay? So I go back here, these are the cusps, you see that? Do you see the catheter going in on the middle, right? So this is the left coronary cusp right there and the left main. So I clock slowly, I'm opening the window. This is below the left coronary cusp. and opening more. You see my lesion starts to show right there. You see that? So that's the top of the left ventricle, and I clog more, takes me to the appendage, and then you're right opposite to the AIV and the circumflex. So this is very basal, proximal, below the left coronary cusp. Yeah, some people call this AMC, but you can see on eyes that this is not AMC, this is pure left ventricle.
Yeah, all right, thank you.
So
Yeah.
I wanna have fun a bit. So I mean, obviously
Yes.
the first two procedures were not the mapping failure. It was energy delivery failure. You know. So the reason why you succeeded today, why?
Well, I haven't succeeded yet because we're having the variation of another one. I think that, I don't know where the lesions were applied before, obviously. I guess that here, if we succeed, it's because we mapped and we find the best spot, but the challenge is the multiple morphologies. So it's almost like you're recovering. So my guess is something in the middle. It's making something go epi and something commendo, if that's the mechanism for this.
I still wanna face you with one fact. First off, I fully agree with you what you have said in your lecture. However, with pulse field ablation, if you have an area that was previously it was thick and it was ablated with pulse field ablation, when we know from the animal lab data that PFA is causing serious tissue thinning. And it might be prudent to go back to the same area and do everything the same. Because now you're not facing
exactly.
10, 11, 12 millimeters of tissue thickness, that you're facing tissue that is down to 6 or 7. So it's different target.
Yeah. No, that was going to be the next step, but because the catheter was open, they wanted to try first with RF. But yeah, you're right. Going back and do the same is not going to be a bad idea to finish the ablation in this region.
I ask the audience, who would ablate here from the left coronary cusp above the left sinus of Valsalva? Because we've seen a couple of PVCs still there.
Well, you don't have to ask that. We can put the catheter there, and we can see if the EGM is good. The left cusp is right here, okay? You can see it on intracardiac echo, and we simply are going to move the catheter back, okay?
There are a few hands. There are a few hands here. Not too many.
Good. All right, there you go. That's the left coronary cusp.
I'm not forcing you to do anything.
No, but it's a good idea. You always, when you do this, you have to map all the anatomical neighbors because that's where you're finally going to get it. So this is the EGM in the left coronary cusp. This is just 2 grams of force. The only thing you always have to do is you see there, that's the left main. So I try to avoid the left main. Okay, you don't see eyes? Yeah, this is the left main right there. You see that? That's the left main on the left coronary cusp. So I always try to be below that. So this is the left main, and this is lower there. So we're going to drop the catheter lower to that region and then see how it looks. There is the left coronary cusp right there. Don't see much of a signal, to be honest with you. That's the bottom of the left coronary cusp right there. You see the catheter? All the way to the bottom of the left coronary cusp. So maybe even that lesion gets to there because you can see the whitening on the tissue when we have a little below. So I think that this is left coronary cusp. The morphology looks a little different, but it's still very basal. So my guess would be go a little bit more lateral, which we will do, a little bit more septal from our lesions, or really the difference is to just do a deeper lesion here, if that's what it comes to, because it's right on the middle, and this is the challenge of this. So left coronary cusp would be one. LV, of course, would be another one. Epi, we ablated from the epi. But at this point, you go back to the drawing board, and you start from the beginning, and you map this one the same way we map the other one to try to figure out where would be the next place, because there is a variation on the EKG. The EKG looks different.
All right, Fermin. I think we may conclude your case. Is it all right?
Yeah,
should we move to somewhere else?
Sure.
I don't know if Vivek is ready for showing any of his case, or should we switch for ECAM? In ECAM, they are ready to conclude.
Yeah.
Okay.
This is all light.
Is Vivek online? No.
Yeah, sit.
So towards the left corner.
Okay,
right
so we are back,
reflection
we are
is
online. So just meanwhile, Ivo kept really kind of homogenizing these channels and ablation, and a lot of energy was needed and a lot of time. We generally have 61 applications, which generally equals to 40 minutes of radio frequency time, so quite large. And then I believe that it shows the limitation of RF. You have to really spend the time to get some kind of outcome and some kind of effect. But we generally, the lesion was extended more to the apical region, and there was some interesting things that we would like to show you. So can we show what we marked in the review screen? Was it? Can we show this? Some of this disappearance of these electrograms that we have. Can we go down? Did we make some kind of very yeah? So these. Can we click on some of those?
Yeah, this one. Yeah.
So these were still kind of remaining late potentials that were inside the lateral wall. Can we click on the next one and the Pruka review? Can we click on the next log that we marked? So these were still decrementing, and the problem was there is a base of the papillary muscle, which makes the whole manipulation a bit more difficult. But still, we ablated more. Can we mark another one? Can we go to the which we there? So they were kind of quite nice still targets. These late potentials. Can we go for the next one that we marked? We just created this. Yeah, this is very long. Can we scroll to the right, because this is during ablation and they all disappear. So go, and they should hopefully eventually disappear. They were in the proximal electrode, and then we just pulled back the catheter and it went to the distal electrode, and this one disappeared. Can we go for the next one? Probably not in this one, but yeah, this one. And can we go to the right? And then we moved catheter, pulled back from the proximal to distal, and then it started to disappear, and it's gone now. So you have an idea. Then we put, again, a remap, and we did try to induce the VT, and we go for 3 extras. Can we show 3 extras? The last one we did, and slow down the sweep street, and the 3 extras show the 12-lead ECG. That is truly 3 extras. Can we 12-lead ECG? Okay, so the 3 extras, and the VT was very easily inducible in the beginning with any manipulation, anything. We had 4 morphologies. Now it's nothing. We could continue, obviously, because there's still a substrate, but the question is whether we should do so, because it's quite a long procedure, a lot of fluid, a lot of RF time. Maybe Ivo will comment on the 3D map. So can we switch to EnSight?
Okay, so you can see here the CT scan. This is the lesion set we did. It took us a lot of time to abolish this basal channel that mainly it's where the ECGI also told us that had to deliver lesion according to the slow conduction because of the papillary muscle mainly and because of the fat. Can you put the fat and the papillary muscles, please? Sorry. This is the fat. Can you hide the fat now and put the paps, please? And you see the papillary muscles just like protecting the substrate ablation in this region. But we finally managed to ablate this region. Can we see the maps, please? The first map, sinus map, then the second one, and then the last one. This is sinus map, okay, with a large area, with 2 patchy areas or 3 of slow conduction. Obviously, it's an incomplete sinus map because of the inducibility. So let's go for the remap. This is the remap where still a lot needs to be done in the same region, in the papillary muscle channel, and in the last remap that we have done. So in the last remap, you have seen that it has really now cleaned all the region. I think down in closer where I am now, there is still some late potentials, but not without decremental properties. So probably we just need to ablate just a couple of lesions here just to close the channel. And if we can move to the ECGI, remember that we are working on the, can we move to the ECGI? Remember that we are working in the ECGI remap. It's not still there, but if you can see it from another view, Esther, please. Okay, like this. In the left, can you propagate the first, this was the basal map. Okay? You see clearly a slow conduction in this region. If you propagate the actual map, it's not perfect, but as you see, there is late activation, but I think there is much less slowing conduction.
So I believe the late activation moved from the kind of late potentials which we saw, and we are trying to abolish more to the kind of different region, and also it's a much larger area. It's because it's the last one.
I think now it's late, but it's not delayed. So it's late because it's the lateral basal
Yes, exactly.
part, but there is no this kind of delay. Can you put the mouse in the area of interest, Esther, please? Here, exactly. And if you see here now, it's much faster, the conduction now. So that's the plan, to be able to be sure that there are no anything else in the apical channel. Move to the inside, please. And it has been nice that, can you propagate the first remap, please? The first remap, yeah. So it's nice if you propagate the maps to understand what's going on. If you propagate it, please, see that there is conduction from both parts of the channels. Put the CT side by side. Okay, so if you see in this transversal channel close to the papillary, there is both conduction from both lateral and septal sides. So you have to close either in the middle or either on both sides. So to sum up, I think we were not able to do functional mapping. ECGI depicted the main deceleration zone, but not the more basal one. That's true. We induced 4 different BTs. I think it's like 2 kind of groups of BTs. So it could be like 2 BTs. We stopped 1 BT by ablation in 4 seconds, but this is not enough because we were still inducing a lot without doing anything. And finally, it's not inducible with 3 extras. We are not 100% happy with that. That's where we homogenize the substrate. But I think 40 minutes of RF in a non-inducible patient, I think it's enough.
All right,
Any
so
comments from the audience to this strategy?
No. Yeah, there is one question.
Very nice case, Ivo and Peter. Can I just comment on, so the appearance of this map, this propagation, is because relatively the electrogram is arriving on this side and that side of where you ablated at the same time. So it's not faster, it's equally slow. You've created block, therefore it's arriving on both sides at the same time, whereas before you had slowing on one side and then so it comes around the other way. So I just want to make sure that it's clear that you've created almost a line of block, and it's now the electrogram is just hitting both sides equally. It's almost like a CTI.
Yeah, I think, however, Magdi, my fear with this kind of remaps, that I'm not fully convinced that it's enough, is that I think it's almost impossible to create a line of block in the ventricle. So when I see this kind of maps, I convince myself it's a line of block, but my feeling is that there is some kind of epicardial connection also that obviously we're not going to ablate today because he is not inducible. But that's my...
I understand, yeah. But what I'm trying to say is there's no way you can make it any faster by ablation. So you've created slowness, and the system annotates the near field electrogram.
Yeah.
So if there's no near field, it'll make the appearance of faster, but it really ain't faster. It's slower or nothing. So I think just the map looks different to what reality shows, what reality is.
Yeah, probably. It's an interpolation of activation of.
And the near field, far field, kind of picking up a different.
Can you show the last map, please, without propagation, just the activation? So in the last map, in the activation, I think it's clearly that there is no slow conduction anymore. So diisochronal crowding, it's clean, probably in the most apical region.
So maybe can you show just for the audience the first sinus map? It's a
with
partial one. Just what we mean by slow means these kind of blue and violet color, because the bar is activation map generated as late potentials or late activations. By ablating this, you generally decrease and you just near the far fieldish kind of.
Especially the first remap, because the one was very incomplete. So the first remap. You see here that decrease a little exactly. You see there are a lot of colors altogether. So it's purple, but it's a lot of colors. It means a slow conduction. But now, if you put the same color scale now, in the last remap, it's the same color scale, so it's purple there, but it's not isochronal crowding anymore. So That's why I think we have homogenized the slow conduction area. So we are happy with that. I think patient is fine, non-inducible. It's not functional S3, unfortunately. CGI was partially capturing. CT was very helpful, I think, to show you from the beginning that it was going to be a very tough case, unfortunately.
The size of the scar could be anticipated as a long application times.
Yeah.
And they are needed, and that's why I believe there are these dual source energy or whatever, which just make this application faster and more effective, especially for this larger kind of substrates.
Absolutely.
Okay, guys.
But I mean, it's not inducible with 3 extras.
Okay, guys, we have to conclude this case because we spent a lot of time. Thank you very much again, and we will move to Homolka. Vivek is waiting for his last input.
Yeah.
Hide all your tags,
that.
please.
Yeah.
Yep, thank you.
Okay, excellent. Can you guys hear us?
And can we be
I know
ready
you
to...
can hear them. I wonder if they can hear me.
We see and hear you. Go ahead.
Okay, excellent. So let me just tell you what we did. We'll start off with as you know, we got pericardial access just before we left. We mapped the epicardium. Now, we're looking from the outside, which is obviously worthless because that's the part that's not touching the tissue. So we have to flip it around and look from the inside. So let's look from the inside, guys. And you can see that really there's this apical region. And I'm not going to show you the electrograms in the interest of time, but there. Actually, how much time do we actually have? Dan, how much time do we have?
20 minutes.
I have 20 minutes to show you? Okay, I guess I can take my time. All right, so...
Vivek, 10 minutes, sorry.
All right, fine. Okay. So epicardial surface, as you can see, there was an apical region, but it was really not interesting in terms of electrograms. So we made the map, and then we got out. And then we went back endocardio. So let's hide this and show the RV endocardium, please. LV endocardium. We didn't do the RV. It's not really necessary. Okay, so if you recall, we had 2 VTs. What I'm showing you here is one of the VTs. Yeah, hide the epi. I don't want to see this. And then let's look at an LAO view. LAO rotated up, please. And then maybe you can split this because they're seeing this as. Actually, can we show them both Cardo and the Pruka review? So let's show Cardo.
Afera.
Oh, Afera. Oops. So Afera and Pruka review, please. I want them to see the electrograms. And rotate this Afera up.
Stefan, can we have them see the Pruka as well?
They're working on it. Okay. So now show LAO. Rotate up, please. So remember, you have a large anterior apical scar. So we rotate all the way up. Keep going up, 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 up. Keep going all the way up. Okay, there. And what you're seeing here, obviously you're seeing the apical part of the scar. And that VT that you see up there, we call it, well, let's call it VT2 because that's what we called it. And you can see the morphology of this with the infero-apical exit. And the earliest point, can you show where not the earliest point, but the best pace map for this was where? And I should note why we did pace mapping because after creating all those points, it turned out to be impossible to create an activation map. There was a problem in terms of the software, and anyway, the system was moving too slowly. So doing an activation map was not going to be realistic. So we did a bunch of pace mapping, and in the interest of time, I'm not going to show you all of that, but that's VT2 exit approximately, okay? So we did a pace mapping all around the border. So that was the exit, so we decided to homogenize this region, and just show the lesions really quickly, please. And so this is a bunch of lesions. There are areas where you don't see lesions, mainly because in those areas, there was no electrograms that were either there or interesting. So that was the first thing, and in each location, in some locations, we delivered 2 lesions if I thought they were particularly important, 2 back-to-back PF lesions. In other locations, perhaps only 1 if I thought the tissue was thin. Okay, after that, let's hide the lesions again, please, and show RAO view. And let's show VT1. So VT1 looks like this. You can see it's a much more basal VT and coming from more superior location. And you see the 2 tags up there above the blue dot. Now rotate to the right. Rotate to the right. Rotate down just a little bit. Okay, right there. So you see the 2 tags really close in the center. It says VT1. There's also one even higher up. There was also a good pace map. So we decided to put lesions here. Can you show the lesions really quickly? And again, a bunch of lesions in this location. I didn't put them all the way up high because the tissue was becoming more normal and I was getting concerned about ablating too much normal tissue. So after these two, then what we decided to do was basically to induce VT. And we induced another VT. If we show the VT3 morphology, you can see, yes, go to the right, good.
Yeah.
And you see this one is also more basal exit, superior. So let's go LAO view rotated down. And we did a bunch of pace mapping here. Now, here's where it became really sort of concerning to me. You see the tag that says VT3? That was the best exit for that VT. Well, it wasn't the best. It was a reasonable point. But if we pace one a little bit higher, a centimeter, let's say more septally, it also looked about the same. So at this point, it was concerning because I couldn't tell if this VT is exiting from this main apical scar going superiorly, or perhaps it's a more complex circuit coming from that region that's more septal, exiting this way. So, and when we pace further down into the scar where my catheter tip is, the morphology was completely off. So we couldn't rely on pace mapping with a long stim to QRS. So the sort of the approaches, those kind of approaches were clearly not going to work. For technical reasons, we're not able to do sort of functional mapping here. So what we decided to do was to induce VT. Can you show and then where that yellow dot is, so we induced VT with the catheter in this location, and let's show let's show this one, show the 12 lead. Show the electrograms. So if you look at the electrograms, and maybe show it at 200 sweep speed. Let's show 200 sweep speed. Okay, if you see that electrogram on P2, is that right? Yeah, on P2, you can see the potential. It looks like either late diastolic or early, certainly pre-systolic, I would say. We had enough blood pressure that we decided to go ahead and try to map and ablate. So we can drop the sweep speed. And when we started ablating at this location, actually we ablated at a different location, a little bit higher up, the green dot that you're seeing on the top next to the ablation catheter. And when we ablated there, you can see we didn't do much, right? Is this the first one? Yeah. Show the electrogram there too at 200 sweep speed. Yeah, 200 sweep speed. And go to the right before the noise starts. Okay. Now the electrogram there is, it doesn't look terrible. It's again pre-systolic, I would say. But it is a much higher voltage, okay? Voltage amplitude. And ablation here didn't do anything. So let's drop to 100 sweep speed again. And then scroll to the left. So ablation didn't terminate. And then I moved down to where the yellow dot was, where we had a better electrogram. Yeah, go ahead and just click on the termination. Yeah, and then ablation here was able to terminate this VT. So there's the ablation. Let's get past it. Go, 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 go. Now we have slow Pruka also. Everything's going slowly today. Okay, and then the VT here terminated. So that happened just as you guys were coming back to us. But then I know you went to other places. So after this, we decided to homogenize in this region. Can we show the remaining lesions, please? And so we put additional lesions in this location. By the way, in case you're wondering, because that's a fair amount of lesions that we made, and you wonder in situations like this, have we now created a lot of conduction delay? The QRS appears to be no different than it was from baseline to this time. Show REO view. The only remaining area where it's interesting potentials is right here on the septum. And the question that we've been trying to decide is how much additional ablation we want to do. I'm sort of leaning against doing it because I feel like if I ablate much more here, I'll be ablating the rest of the Purkinje system on the septum. But anyway, that's what we've done so far. Any questions so far or comments?
Any questions from the audience? No, there are not. Maybe I have one question. Do you prefer to apply at each site 2 PF deliveries or?
Yeah, I do. So we have a manuscript. I think it's in press already at CircEP, where we compared in a preclinical study different strategies. Obviously, two PF. Okay, so we compared 4 different strategies. 1 PF, PF followed by RF, PF followed by PF, then RF followed by PF, okay? And what we saw is there's 1 PF, if you put a second PF, so 2 PF is more than 1 PF. I don't think that comes as a surprise to anybody. So then the question then becomes, what if you do RF first and then you do PF, right? Heat up the tissue and then use PF. It actually is the same depth as 2 PF lesions with more variability on the low end, actually. So the 2 PF lesions give you the same depth with less lesion-to-lesion dimension variability than doing RF followed by PF. By the way, if you do PF followed by RF, it's like useless. It's worse than, it's just a little bit bigger than a single PF lesion. So because of that, I tend not to use RF unless there's a specific reason, like near conduction system or something like that. And I like to do 2 PF lesions at each location. In this case, because there's just so much to do, we decided, in the critical locations, we do 2 PF lesions. But in other locations, depending on the location, sometimes I'll just do a single PF lesion.
Do you prefer to start with PF? Because what you have just said, that if you would like to start with RF, you may start PF on RF. And now if you want to continue with RF in some, let's say, difficult site, you can't do this because after PF, RF is, as you said, useless.
Yeah, but RF is fairly useless anyway, right? I mean, what I mean by that is with the current delivery methods, I don't really like RF. I think that the 2 PF lesions seem to do as good of a job. Now, there are advantages to slowly cooking with RF, which I 100% agree. If instead of trying to do these fast lesions, we drop the power and we did a 30 or 60 second lesion, then I think you do get greater depth, right? The problem with that is 30 to 60 seconds per lesion. And when you have such a huge scar, unless there's like a single area that's really deep that you're worried about, I just don't know that it makes sense to do that routinely.
Stefan, can you put ice as well?
So anyway, I'm not going to do a lot of lesions here. I don't like that idea. But there was just one area that I thought was sort of interesting. Okay, we're almost done with my 10 minutes. But so at this point, I'm going to look around a little bit more. And then what we'll do is probably do one last induction and then get out of here.
Vivek and Devi, we get a signal. We have to slowly conclude this case because we have to go and wrap up another 2 cases. Obviously, it was an extensive scar. I think you did a good choice to do that homogenization of the septum. The way that that FastVT initiated based on EGMs from ICD, I think it was typical for some septal reentry and then spiral wave breaking and going to VF. So I think I would definitely I think it would be you're doing a good job for a patient. And with that, we have to salute you. Thank you for showing us the technology.
Thank you very much. Good to see everyone.
And see you soon. Bye-bye.
Wait, before I forget,
so now,
make sure you join us.
Shall we go back to Professor Kautsner?
Okay.
Iken? Hello?
Chápu.
Professor Kautsner?
Už jsme tam. OK, tak.
Please update us on your progress.
Can you handle it?
So
when we left your pace mapping in the right coronary
we
cusp,
had a very good pacing site in the aorta, in the right coronary cusp, with a percentage of correlation of 90, and you will see right now the yes, that's the site here, and. So we burned here, and we burned also, so you have these different points here, and we burned also in the left ventricle in an area where the percentage of correlation was pretty good. So as we mentioned before, we have a gradient from this zone here going especially to the septum. So I suspect that again there is a reentrant circuit going on here, rotating like this. Yeah. So that's what we did. And after we did that, we decided to do some substrate ablation in the inferior wall. And so this is a new map of the left ventricle. And you see, for example, this electrogram very fractionated. So we have a high fractionation level on the septum. And we did some pace map as well, just to look at the SQRS interval, which was pretty long in all this area, and Joseph started to burn this zone here. Meantime, we also did some pace map in the left ventricle at different sites because, and we did not show you that before, before we could induce the VT, we had several runs of non-sustained VT, and one here is very interesting because as you see the morphology, it's negative in 2,3-VF, positive in V1, V2, and you have a transition between V3 and V4, which suggests an inferior origin in mid-distance, I would say, between the apex and the septum and the base, but closer to the apex. And this would fit with the inferior wall, in fact. So we decided to pace here, but we don't have many points so far. And the best correlation we have is 73%. You see the point here at this area here. But again, we don't have many points in terms of pacing. But still, I think Joseph will go on burning on the septum all these fractionated potentials. And because again, we have an anterior substrate, which maybe is related to a non-ischemic cardiopathy. And at the same time, we know that the patient has also an ischemic, so it's a mixed ischemic and non-ischemic in this patient. The origin of the right ventricular outflow tract is, of the left ventricular outflow tract and the coronary cusp is very specific of what we see in non-ischemic.
If we can see echo, intracardiac echo, you will appreciate again that there is a huge aneurysm anteroseptal. And with thinning of the wall, and we have a lot of these fragmentations on the boundary of aneurysm. So we decided to do sort of core isolation of this aneurysm. But it will take some time, and I think, as you heard, we believe that these are two different things. This aortic area is a substrate, typical substrate for non-ischemic, and the patient has this big aneurysm, which has a lot of slow conduction. There are late potentials, so we believe that we should isolate the core of this aneurysm, and that would be to prevent any future arrhythmias from this area, if we are already here. So this was quite complex case, which we believe that there will be nice arrhythmia coming from the aneurysm, but it was not the case. But I think to show the principle of pace mapping as Christian developed, I think it was quite instructive. And yeah, now we will continue to modify this area to do core isolation. And maybe tomorrow we will tell you how it ended. But the inducibility here is very problematic, so we can't rely on that.
You see there is a point here with a correlation of 91%.
So we have correlation here for this non-sustained VT, also quite high. So it will be in this septal part, I believe. So we will work on this, but that's for another at least 1 hour of work. So we will have no time to show you the result today, but we will explain you later.
Yeah.
Any questions?
Any questions from the audience? Yeah, by seeing eyes, it's clear that you have a work to do, and there it's not easy to do it with a focal something, and just take time. And
it would be nice to have large footprint stuff.
Good. We're going to pursue the conference. Thank you for a nice case.
Unfortunately, there is no coffee break. All right, so we have